Good evening. It's the final event of today. Uh, we heard an excellent talk by Dr. Sharmagavelu on dapagliflozin. How to further improve the effect of dapagliflozin is to use it in combination. If the HbA1c is 1.5% above the target, it is welcome straight away to use a combination of drugs, especially a combination like dapagliflozin and vildagliptin, and it will help us to quickly achieve the target. And many side effects of the drug like SGLT2 inhibitors may be reduced if you use with the gliptin. To tell us more about this optimum clinical approach to use Vilda-DAPA combination in Indian settings, I invite Dr. Adeline Reena Asirvadam, DNB General Medicine and DM Endocrinology. She's the Associate Professor of Endocrinology at SRMC, Chennai. Over to Dr. Reena.
Thank you, sir. And I thank Microlabs for having me here to talk about on the optimum clinical approach. So many times when we approach to manage type 2 diabetes, we often are misleaded or misguided by the fasting plasma glucose, the postprandial plasma glucose, the affordability of the patient, the comorbidities of the patient. So what I'm going to emphasize in the next 15 to 20 minutes is to clinically look at a patient and how we really choose to probably prescribe this combination of vildagliptin and dapagliflozin, which is the molecule for discussion today, in Indian settings and for our patients. So this is just a prototype case. This is about a 49-year-old gentleman who's an executive by profession. By the term executive, we all know about the sedentary lifestyle that tags along with that particular profession. And patient seeks for glycemic control. So when patients seek for glycemic control, it becomes more easier for us to convince the patients to intensify therapy or intensify lifestyle modification, rather than we picking up an A1C of 8.59 and striving hard to convince the patient to again intensify therapy. So digging up the history, patient has diabetes for last 2 years with associated hypertension, dyslipidemia, has had failed metformin monotherapy. He was initially on 500 milligrams twice daily, then increased to 1000 milligrams twice daily for an A1C of 8.3. So on examination, we find that patient is obese with signs of insulin resistance, BMI on the higher side, blood pressure controlled on antihypertensive. When you look at the biochemical profile, we see that the fasting plasma glucose is high, the postprandial is again high with an A1C of 9.2%. So what we need to understand is this particular gentleman has both fasting as well as postprandial hyperglycemia, a combined abnormality which needs to be addressed, and that's how we will be able to bring down the HbA1c. And looking at the cholesterol is not very satisfactory despite being on a rosuvastatin of 10 milligrams. Luckily, he has a normal renal function, giving us a lot of room to probably play with the anti-diabetic drugs that we have now. So going back to the details, we all know that type 2 diabetes is increasing steadily and steeply worldwide, and India is no exception. So what you see here in numbers based on the IDF projected data, we will soon become the diabetes capital, or probably we would wish to become the diabetes care capital of the world. Now, how are our patients different? Our patients are definitely much different from the Western counterparts, and the reasons here are listed here. Apart from the environmental factors that are more or less the same between the Western population and our population, what we need to understand is this particular column. So we have a very conceiving low body mass index or a low BMI. The moment you check a BMI, it is branded as a normal BMI, and many times it is very misleading. But unfortunately, when we really need to measure or probably put these patients or probably risk stratify them, it is the waist circumference of our patients that will really give us a clue of the visceral adiposity, subcutaneous adiposity, and probably the metabolic risk as well. So a higher waist circumference and a high waist hip ratio will indirectly point towards a high visceral fat, and this particular fat distribution makes these patients more prone to succumb for cardiovascular and metabolic complications. So this in turn causes an increased insulin resistance, a very high prevalence of atherogenic dyslipidemia, and more importantly, what we are as physicians concerned is the early beta cell defect. Many times we see patients failing one drug, two drugs, three drugs as early as in the course of type 2 diabetes, possibly because of the inherent beta cell defect that our patients encounter. So why are we very concerned about this particular Indian phenotype? It's because these patients have diabetes at a younger age, have diabetes with normal BMI, and are more prone to develop cardiovascular complications and succumb to cardiovascular events. So that is the reason why we are more concerned about our patients and as a whole, and not just looking into a narrow spectrum of just bringing down the numbers of the plasma glucose. Now, the type 2 diabetes doesn't come alone. It always comes along with a lot of friends. So what we also understand is that almost when you see 85% of patients have associated dyslipidemia, 75% have hypertension, 50% of Indian patients do have chronic kidney disease. So when you keep tagging and keep looking at the various permutations and combinations, you find that type 2 diabetes as an isolated abnormality happens in a very, very few subset of patients where you have a combination of all these abnormalities tagging along with type 2 diabetes, making it a bit more tougher for managing the patient and not just type 2 diabetes. Now, unfortunately, though we talk about all these comorbidities, they don't come in a very broad daylight, and we have a lot of our patients having asymptomatic cardiovascular disease. What you see here is that at least 60 to 70% of patients have LV dysfunction at different stages, which remain asymptomatic, and many times it is often missed because it doesn't present in the classical way. And again, when you look at cardiac failure, again, at least 25 to 30% of patients do have asymptomatic heart failure. Now, this makes our patients more prone to have cardiovascular event and also cardiovascular death. So how do we really go about looking at these patients? We often are familiar with this particular term, the cardio-renal metabolic continuum. So when you try to see a patient, we have to place the patient in any one of this journey or the course of type 2 diabetes and the metabolic complications. So they start from being diagnosed with hypertension, diabetes, and obesity, and they slowly progress. What you see here in the outer circle is the macrovascular complication, having a cardiovascular event, ventricular dysfunction, and ultimately succumbing to cardiovascular death or stroke. And then in the inner circle, you find that patients have endothelial dysfunction, macroproteinuria, and ultimately ending up having an end-stage renal disease. So if you have an individual with type 2 diabetes, we would rather want to place them at some point of time, and what we really intend is to hold on the patient in that particular phase so that they don't progress in terms of not just type 2 diabetes, but also diabetes-related complications. So having looked at about all the Asian Indian phenotype and how they are more prone for all these complications, how do we really improvise the type 2 diabetes management? Is that something which we can do? So if we are able to have a combination therapy that could address the multiple pathophysiological abnormalities which contribute to hyperglycemia and type 2 diabetes progression, that could help us to at least retard the progression to some extent. And when you have a drug which not just provides glycemic benefit, but also non-glycemic benefits would help, and a drug that has to achieve the same glycemic efficacy, but not at the cost of hypoglycemia and weight gain, and more importantly, which would help these patients to have some adherence to therapy and compliance so that the dropout rates and the poor HbA1c doesn't happen. And more importantly, the durability of glycemic control. We often talk about the sequential therapy, and now we know that it is not always the sequential therapy that helps. Rather, hitting them hard and hitting them early with combination therapy helps them to have a sustainable and a durable glycemic control that can prevent microvascular complications, especially when achieved in the first 2-3 years of type 2 diabetes. Now, looking at this molecule as a combination of SGLT2 inhibitors and DPP4 inhibitors, there are two different molecules having mode of action, site of action at different places. But what we also understand is that they complement each other and ultimately offer a better glucose lowering effect. So when you look at SGLT2 inhibitors, they potentially act on the kidneys and therefore cause renal glycosuria and improve the glucotoxicity. On the other hand, we have DPP4 inhibitors, which have a predominant effect on the pancreas, both the alpha and the beta cells, and also on the intestine, increasing the endogenous GLP-1 and GIP, and ultimately contributing to diabetes control. So what I mean by saying complementary is that we know that SGLT2 inhibitors can potentially increase the glucagon secretion, which is suppressed by DPP4 inhibitor. So the diabetic ketoacidosis risk that is possibly due to SGLT2 inhibitors is kind of neutralized when it is given along with DPP4 inhibitors. Now, to add on to this combination in the kind of patients which we discussed, when these two molecules in combination is added along with metformin as a triple drug combination, what you see here is that the entire 8 pathophysiological abnormalities that contribute to type 2 diabetes is being addressed, and overall we get down into the core abnormality of type 2 diabetes, and we are able to not just bring down the glycemic control but also to improve the metabolic milieu of the patient so that we can prevent type 2 diabetes related complications. Now, whenever we talk about combination therapy, the first and foremost combination that comes to our mind is sulfonylurea and metformin. It's one of the pioneers of using fixed drug combination is India. We've been the pioneers in starting the sulfonylurea metformin combination. Though it is a very powerful combination, many times the hypoglycemia, renal benefit, and other extra glycemic benefits are not addressed. We have the DPP4 and metformin, which has a good potency in terms of glycemic control and low risk of hypoglycemia. And when you add in an SGLT2 inhibitor to this combination existing pool, what you see is a holistic benefit of metabolic abnormalities. Now, beyond the glycemic control, beyond the metabolic abnormalities, there is something which these combination drugs can also do. So the time in range is gaining importance now. We are not just bothered about how the HbA1c looks at the end of 2 months or 3 months, but we also want to know the quality of glycemic control, how far and how flat the glycemic excursion really plays over the day, and probably inter-day variability. So by improving the time in range and by reducing glycemic variability, the combination of DPP4 inhibitors and SGLT2 inhibitors brings down the complications due to type 2 diabetes, because we know that glycemic variability per se has an independent prediction of microvascular complications due to type 2 diabetes. So that way we are definitely able to bring down the complications and possibly improve the outcomes of these patients. Now, how does this combination, though theoretically addressing multiple pathophysiological abnormalities, very good drug to reduce the glycemic variability, how do our patients fare in this combination? This is an Asian cohort which was studied, especially in this meta-analysis. And what you see here is the glycemic response or efficacy of the molecule in Asian Indians. And what you see here is that the SGLT2 inhibitors did show a better A1C reduction in Asian population compared to the Western population. DPP4 inhibitors, again, numerically better, but statistically not very significant. So when you have a combination of these two molecules, which do better or probably offer better glycemic efficacy in Asian population, because of the fact we know that our patients' pathophysiological abnormalities are quite different from what has been proposed in the Western population, these combinations really work well. Now, this is an unpublished data of a study with fixed dose combination of vildagliptin and dapagliflozin. And this was a 16-week study where they primarily looked at the mean change in the fasting plasma glucose, 2-hour postprandial, and also to look at the proportion of patients who achieved an A1C less than 7% at the end of 16 weeks. So they had included around 318 patients and had 3 arms. Patients were randomized into DAPA 5 plus Vilda 100 SR and DAPA 10 plus Vilda 100 SR and DAPA 10 with saxagliptin 5 mg SR. Now remember, the US FDA has approved the combination of DAPA 10 mg and saxagliptin 5 mg, but we don't have the combination available in India. But what we do have is the combination of Vilda and dapagliflozin. Now, if you look at the 16 weeks results, what you see here is the A1C reduction close to 1.5, 1.6%, as good as the DAPA-SAXA combination. And there isn't much difference between the DAPA 5 Vilda 100 and DAPA 10 and Vilda 100. And onto your right side is the fasting plasma glucose reduction, almost to the tune of 30 milligrams per deciliter. And also when you look at the postprandial control, again, a good significant postprandial reduction also achieved with this particular combination. Now, when you look at the proportion of patients who achieved an A1C of less than 7%, close to 50 patients were able to achieve at the end of 16 weeks. So overall, this study showed that the glycemic efficacy is on par with the US FDA approved DAPA and SAXA combination. Now, when they looked at the adverse event profile, what we can see is the adverse event profile is very comparable. You don't see any vague increase in adverse events with this combination of VILDA and DAPA and in this particular study. So looking at the data behind how these two drugs, when prescribed as a combination, would probably impact the cardiovascular system. So when you look at the comparison of dapagliflozin and vildagliptin in this particular study in patients with diabetes and a coronary artery disease, you can see that most of the graphs or most of the parameters, you see that DAPA and VILDA are in synchrony. The effect of DAPA cannot be matched by VILDA, but what you also see is that at least it is in the same direction, except for the body weight, which we all know SGLT2 inhibitors do offer weight loss compared to the DPP4 inhibitors, which are weight neutral. Now, the interesting fact is about not just complementary mechanism in terms of glycemic control, but also the complementary mechanism in CV benefit. And that's what we are more probably interested. So what you see here is a reduction in the NT-proBNP marker over a period of 6 months of use with dapagliflozin. And you also see a good amount of reduction in the NT-proBNP with vildagliptin at the end of 6 months. So overall, they work together in synchrony and complement each other, not just in glycemic control, but also in bringing down cardiovascular risk and probably offering a bit more cardiovascular benefit. Now, this is a preclinical study because we don't have the clinical study for cardiovascular benefit as of now. And what you see in this particular animal study is that the cardiac ischemic reperfusion injury is quite common in patients with type 2 diabetes. And when dapagliflozin was added in these animals, what they showed was there was a significant recovery from the injury. But when they added vildagliptin over and above the dapagliflozin, they still saw a further increase in terms of the ischemia reperfusion injury size reduction. So this kind of tells us that DAPA, yes, we have very clear data to say that it does have an effect on the cardiac ischemia reperfusion injury, but vildagliptin does no harm or probably adds on to the benefit a bit more. Now, a quick word on the beta cell function. And as diabetes care specialists, we also know that we are more interested to provide a drug that could be durable for the patient so that the patients can be on a single pill with 2 drugs on, and you can forget glycemic control for the next few months or few years. So one such benefit that this molecule can offer is the beta cell function improvement. We know that DPP4 inhibitors have an impact on the beta cell function and has also been shown to have some beta cell preservation effects. So what you see here is all the gliptins that have been studied, including SITA, VILDA, LINA, and all of them showing an improvement in beta cell function and possibly the reason for having some beta cell preservation as well. Now, talking about the adverse effects, whenever we have SGLT2 inhibitors, we are more concerned about the possible increase in the genital and urinary tract infections. Of course, we do have an increase in genital and urinary infections while being on SGLT2 inhibitors, but when this combination is given, what we understand in this particular meta-analysis is that right from the Rosenstock data to the DeFronso data, what you see here is the combination of SGLT2 and DPP4 does have a very less prevalence of genital and urinary tract infection, more importantly, genital infection. And the proposed mechanism is 2 or 3, one being a good glycemic control, automatically bringing down the incidence of any infection for that matter. The second thing is the presence of the DPP4 enzyme in some of the bacteria and fungi that can contribute to this infection. Once that is inhibited with DPP4, it has been shown that possibly that could be the reason why the infections are much less in a combination. Now, there's an expert opinion that has been published a couple of months ago for the optimum use of SGLT2 inhibitors and DPP4 inhibitors. And what this panel recommends is to consider the FDC of VILDA and dapagliflozin when you really anticipate for an improvement in glycemic control, adiposity, also want to reduce the metabolic and vascular risk. At the same time, you want to have a simple regime and a regime that can really work for our patients. So the key takeaways from this expert opinion for Indian patients include the combination of SGLT2 inhibitors and DPP4 inhibitors can be considered when you have an A1C which is at least 1.5% above the target HbA1c. The second thing is whenever you have comorbidities in the patient, either established cardiovascular or renal disease or possibly a high risk factor for cardiovascular and renal disease, you may still consider this combination too, not just for glycemic control but also in the risk factor reduction. And when you want to offer a good glycemic efficacy without hypoglycemia and weight gain, you may consider this. And more importantly, to bring down the pill burden and improve adherence, which is many times overlooked in our clinical practice. So coming back to our patient, he was continued on lifestyle modification. Metformin again was continued at 1000 milligrams twice daily. He was started on vildagliptin 100 and dapagliflozin 10 milligram FTC once daily. On follow-up, you can see a bit of weight reduction, a good fasting and postprandial control with an A1C reduction and good A1C reduction achieving a 7.4%. So this kind of a benefit is definitely possible when you have a combination therapy early on board and when patients are able to not just bring down the glucose levels, but also the cardiovascular and renal risk. So to summarize, Asian Indian phenotype is definitely different from the Western counterparts. They have an increased visceral adiposity, a lower metabolic tolerance, and therefore have a very, very high cardiorenal risk. And more than just following the guidelines, many times we should have an individualized approach to every given individual that we see across the table before we make a decision on the anti-diabetic drug that would suit the patient. And last but not the least, whenever you have an opportunity to provide a drug that can address the core abnormality of type 2 diabetes that causes not just type 2 diabetes but also the progression of type 2 diabetes and beta cell function worsening, then it would be prudent to choose such a combination when you really want to address the abnormality directly. So thank you very much, and I will stop here.
Thank you, Dr. Edlin, for the excellent talk. I open the floor for discussion. Yes, sir.
Yes, good evening.
Good evening, sir.
About combo therapy, there is one positive and one negative. The positive thing is it improves patient compliance. The negative thing is we cannot titrate. That's all.
True. In this particular FTC, we don't have an option of titration because both come in a fixed dose and it's a once-a-day therapy. So that way, when you are looking at a Vilda 100 milligram sustained release with a dapagliflozin of 10 milligram, that's it, and that doesn't really warrant a dose up titration unless a patient is on other drugs which might have to go up or go down.
Unless the patient is on having CKD or something, there is no need to titrate this dose. 100 is the single dose and 10 is the single dose.
In patients having blood sugar less than 200, I think metformin alone is enough.
Blood sugar less than, sir?
200.
That's what I was. The entire message is not just to go by the glucose value per se. When a fasting plasma glucose, if I can take it as 200, that clearly tells us that the hepatic glucose output is huge and may not be just possible with metformin alone. So probably you need a drug, because if the fasting is 200, I expect the A1C to be...
Not fasting, postprandial, PP.
Postprandial.
I think... or random. And I recommend random more than PP or fasting. I recommend random. Anytime, anywhere, anytime, a normal human being must have a normal glucose level in blood, not during fasting or postprandial.
So I don't. Here, she clearly mentioned that if only we use this combination if it is 1.5% above the target. Yes. If it's below 200, we are not going to use this drug.
Yes, and one more. This quinolones, talking about quinolones, they bring down blood glucose.
Which one, sir?
Quinolones.
Quinolones.
Yes.
Quinolones are potent to cause hypoglycemia, which is
yes.
more common in patients without type 2 diabetes. So, non-diabetic hypoglycemia, one of the commonest causes the fluoroquinolones. But the dose that we use in clinical practice doesn't really cause hypoglycemia. The dose which was previously used was a very, very high dose. So that was a dose which has been clearly shown to have hypoglycemia. But what we use in our clinical practice, we don't get to have hypoglycemia unless patient takes it in an intent to overdose him or her.
Does it improve any SA node function?
Which one? Sorry, sir?
Any SA node function improvement?
SA node.
Yes.
Quinolones, yeah. The QTC prolongation is one of the known complications.
QT prolongation.
Yes.
QT prolongation over quinolones along with cetirizine, along with antihistamines. It is even more.
Antiarrhythmic drugs, yes. When there's a combination, yes.
Thank you.
Thank you, sir.
So due to time constraints, we are forced to end this wonderful session. I once again thank Dr. Adeline for the wonderful talk.
On behalf of Microlabs, we thank Reena Madam and we thank Sridhar Sir and thank all the participants. And once again, on behalf of Microlabs, we are thanking all of you, sir. Thank you. And we are very much trusting this Vilda plus DEPA. Definitely, it's going to be a trendsetter from Trendo. Thank you. Thank you, all of you. And thanks, Trendo, for this wonderful opportunity.